tentang Sssl ni. Okay, what do you understand by Sssl? Huh? What is it? What do you understand by Sssl?
Make sure correct patient, correct surgery, correct site of incision. Hello?
Okay, yeah, I can hear you. I can hear you. Okay. Okay, guys. That is the gist of this initiative. Actually, it is initiative actually started by WHO back in 2007 as part of the patient safety initiative. And then this initiative has been taken up by Ministry of Health in Malaysia. The first meeting done on 2008, and then subsequently this initiative using of checklist is implemented throughout Malaysia in 2010. But by 2010, everybody in the hospital is using this checklist. Do you think this checklist is used in our hospital?
Yes.
Oh, saya tak pernah nampak sebenarnya. I never check it, so I don't know whether it's used or not. So what is the objective of we as a doctor? One is not to do harm to the patient, kan? Secondly, to ensure we give something benefit to the patient. Benefit with our setup actually as a doctor to give treatment, which is beneficial, better than the risk of the treatment. So it is ethically, morally our responsibility to the patient to ensure patient safety. So if you baca in WHO punya guidelines, complication can occur in up to 22% of surgical procedure. That's at the industrial region, industrialized country. Whereas that rate is about less than 1-2% in industrial country. Kalau compare to developed country, this death rate is higher, up to 10%. Itu banyak beza kan. So and from this surgical complication, 50% of this actually surgical complication is preventable. So this initiative is to tackle all this preventable adverse event. Kalau kita tengok kan, patient harm is one of the leading cause of global burden, disease burden. Sama dengan tuberculosis dan malaria, nombor 14. And the cost of this consume about 15% of hospital expenditure. Banyak tu kan. Kalau hospital ni dapat 1 bilion, maknanya berapa? 150 juta habis kah treating all this patient harm. What are the adverse event can occur to the patient? One is wrong surgery. For example, this patient plan for right axillary tail removal, you buat apa? Right chest wall excision. Terbalik kan? Right chest wall excision, you buat right axillary removal, axillary tail removal. Same time, so you want the patient require left craniotomy, tapi you buat right craniotomy. Sepatutnya patient tu buat right herniatomy, you buat left herniatomy. That is wrong surgery. So it's become now with the media sosial kan, orang tak boleh lari daripada patient punya apa ni, unhappiness, they come to the news kan. So kalau kita tengok baca dalam news ni kan, patient ni cedera kat kepala tapi pembedahan dibuat di kaki, that is wrong. Then now patient can summon doctor because we are careless in doing surgery. Why we do this? Why this mishap happening? Why? One, because there is no proper checking. You have checklist. The checklist is not done. The site of surgery was not marked. You have been working on call at night, and then suddenly you have to do surgery in the next day. Then you get tired. You have lack of concentration. Then you operating without knowing the patient beforehand. And you suddenly patient being called to come to OT, patient already on table and don't have time to review patient notes and take consent. All these factors lead to error. And then sometimes you are the most junior, you are being asked by your senior to do surgery without proper supervision. That can cause error as well. Not just patient, we as a healthcare provider can also get the effect of it. A lot of healthcare professional, doctors and nurses, significantly emotionally disturbed due to this adverse event. In one study, up to 80% of those healthcare professionals they develop this, become second victim. The more the serious the error, the more the intensity of the physical emotional disturbance. And among the emotional atau physical emotional disturbance which can occur increase anxiety about future error, decreased job confidence, decreased job satisfaction, increased sleeplessness, and your reputation also harm. So what is Sssl? The objective is just to improve patient safety and reduce harm. So if you go read at the WHO initiative, there are two main objectives: to address inadequate anesthetic safety practice. Secondly, to avoid surgical infection, wrong surgical site impression, poor communication among team members. How does it carry out? One is to use checklists as a tool to ensure safe practice during surgery. Secondly, to improve communication and teamwork to ensure safe surgery. If you go back, read the Sssl Malaysian 1, they set it two goals. One is zero wrong side or side. Second goal is zero unintended retained foreign body. So the checklist is doesn't mean that you don't do proper right way of surgery, but help us to do all the thing right on all patient and at all time. So by doing checklist, we can promote areas to establish safety practice. And this checklist is supported by the evidence. There was studies done and pilot study done on this checklist at 4 major hospitals in the world, at Manila, Auckland, New Delhi, and so on. They found out that by applying this checklist, they can reduce the rate of post-operative complication and deaths for more than 1/3. So in Malaysia, how does it implement? Usually in the hospital in Malaysia, in government hospital, they have hospital Sssl committee. This committee will promote, make education, and to ensure that the checklist is implemented by providing the checklist available in operating theatre in the wards. They also do regular auditing to make sure the checklist is done in at all time. It is mandatory to use the checklist. Any patient undergoing surgery checklist must be performed. And the role of surgical team as a doctor is to make sure this checklist is used by demonstrating good leadership skill and create safe culture. Nurses in the wards and in OT is their duty to fill up the checklist. The checklist has 4 pages. The first page is peri-operative checklist. Second page is operating team checklist. And third page is swab instrument count checklist. And page number 4 is pre-discharge checklist. This checklist is filled by ward nurse and OT nurse. So while patient in the ward before coming to operating theatre, surgery team will review patient, check the allergy history, take consent, cite the mark if it is necessary, make sure the antibiotics are ordered, and trace all the notes, investigation done to this patient. Is the GSM required? He must order it. And if certain instrument or equipment required during surgery must be ordered. Okay, before sending to OT, this section of peri-operative checklist will be filled up by the ward nurse. And these 2 sections, they will go through the notes to the patient, and if it is done, they will tick in the box. And then when patient will into OT in the receiving bay, then the second part of the second row of ticks in the peri-operative checklist is done by the OT nurse in the presence of the ward or nurse. They check it, and then both of them will sign in front of each other in the session pre-transfer checklist. The last column in the peri-operative checklist is filled by the OT nurse when patient will to the operating theatre. Okay, this is the important page. Actually, WHO safe surgery, safe rights only consists of that. The rest of the pages in this our Malaysian Sssl is additional to improve the service in our setup. So this first the sign in to be filled by nurses, coordinator, security nurse usually. This will address before patient induction of anesthesia. We call it sign in. This will address safety, anesthesia and resuscitation. This checklist, the list is checked by the nurse once the doctor anesthetist perform all this list. And before skin incision, there is a term we call it time out. So at this section, we'll address correct patient operation site, minimum risk of infection, to minimize risk of infection, and effective teamwork. The whiteboard is written by doctors, Anesthetist, surgeon, and nursing team review the patient and anticipate if there is critical event might occur during the surgery, and estimate the time of surgery and instrument what to be done, and so on. What are the common problems in this section? Usually, in that is what occurred in the past, probably not occur now. So sometimes patient will to OT, the surgery is not arrived yet. That's supposedly not happening now. Doctor does not write the whiteboard. I see in our setup, most of the time when I go into the OT, is completely filled by the doctors. Team member familiar to each other, so they feel how to introduce themselves. Actually, you don't have to do it, you don't have to fill it. Just do it. Don't worry about that. Sometimes the security nurse does not see anesthetic team checking the GI machine. So when the security nurse does not see this, so the nurse should not tick on the box. Or the other way around, usually the nurse can tell the anesthetic team to do it, and after that they can tick that. Sometimes because of busy OT, preparing something, the nurse forget to fill up, to tick the box. That's another issue as well. So surgeon who is involving in the surgery must take a role to make sure this checklist is done properly. Okay, the next section is the intraoperative communication during procedure. This will address good communication between team members. There are four sections in this intraoperative communication. First one is check-in. So when you want to start the surgery, you must communicate with anesthetists and scrub nurse to determine their readiness to commence surgery. And then once you start the surgery, every now and then, especially if surgery is more than 1 hour, you must update the team member. Where is your progress? What happened to the surgery? Where are you? Just update the team member that how far you have gone to the surgery. Third one is shout out. It is act of vocalizing clearly on certain intraoperative events in order to obtain undivided attention. For example, when you put abdominal pack into the body of the patient, you must voice out that one pack in, so that the nurses who is assisting you, scrubbing with you, will alert and mark it into the count, swap count. If there is instrument drop, you must voice it out so that the team member is alert, especially not just cause instrument drop, because they have to take it and put it in the same place. Sometimes the item is not functioning, you must voice it out as well, so that the surgery runs smoothly and probably they can get the better one. If there is excessive bleeding, or patient become unstable, you must actually inform the nurses or the anesthetist, so that the anesthetist can get ready with the blood or make sure the fluid is infused to the body adequately. And last one is pre-closure disclosure. So during this time, when at the end of surgery, you must inform the team members that we are towards the end of the surgery. So this will enable the anesthetist to get ready to reverse the patient. The scrub nurse also will start commencing the swab count and instrument count, and then she will tell you the result of this swab count before you close the peritoneal cavity, because close the anterior wall. Because the swab count is inadequate and not enough, you must thoroughly check the body of the patient to search from the swab. So this will let the team member also to care to prepare for the next case, to call to the OT, so that there will be good timing between first and second case, not wastage of the time. So there must be communication between you and the other team members, so that if there is mishap happening, the other will help you. It is a teamwork, it's not just individual work. You might be smart surgeon, good surgeon, but if your anesthetist is not performing the job, error can occur. And then once the surgery complete, you have closed the abdomen, then come the session of sign out. So you tell the family member, tell the team member, summarize what is your finding and the procedure. Surgeon verify the HP specimen, and then you might need to discuss with the anesthetist what are the post-operative issue occur by each patient require further monitoring in ICU. You must tell the anesthetist and discuss with anesthetist, or anesthetist might tell you that patient is not stable, require further ICU management. That will be the time to discuss with them. If there is issue with the instrument, you must inform. Sometimes the blade or the what do you call it, the diatomy is malfunction. You must get new one for the next surgery, better one. And then at the end, in certain cases, especially in high risk or major surgery, then you might need to inform the patient relative straight away. Depending on the local setup, when to inform relative. Sometimes for call stable case might have to inform after the receiving patient back to wards. Just the other way. Okay. And the stage page is documentation on the swab count. So the count must be correct. It must be tallied from initial, second, and third count. And then the specimen is labeled and documented what type of specimen are there, how many specimen available, and incident if there is failure so written inside this section. Okay. Then patient will into the recovery area before patient transfer back to the ward. There is another section, page number for pre-discharge check. This region is, this area is filled up by recovery nurse with the presence of ward nurse. Then the checklist is thick and then kept in the BHT. So this checklist is compulsory to be filled for all operative procedure in operating theater. But however, compliance to this checklist is still low. This is the audit done by Kementerian Kesehatan to, I think, 8 hospital back in 2017. And then from the audit, the compliance of this checklist is very low. Non-compliant is 68%. They found out that 3 out of 10 Sssl checklists were completely properly filled up. So it is our duty now. All of you going to be surgeon, make sure this checklist is completely filled and properly filled, so that we hope that we can reduce the error, adverse event which can be preventable to the patient. Okay, that's the end of my slide of this topic. Okay.